While National Registry style questions are normally very minimalist, when National Registry questions give you a lot of information, there's usually a reason for that information. And this question, I believe, gives us a really great example of how we have to sort through very important information. All right. So let's read the question. 5-year-old female is in respiratory arrest. As you begin to ventilate her with a BVM, her vital signs are pulse of 64, a respiratory rate of 20 and assisted. Remember, the new Heart Association rates say 20 to 30 is the ventilation rate. Blood pressure of 92 over 68 for a 5-year-old. That's not the issue. And saturation's 88%. Okay, that's an issue. That's on supplemental oxygen. After 5 minutes, her vital signs are now pulse of 100. You're still bagging at 20 times a minute, but the blood pressure is 60 systolic and the saturation's 99%. You should suspect the change in her blood pressure is due to increased. Now, I took the National Registry exam myself, and I read every question twice. So I just read the question. Now I'm going to go back and I'm going to see what's important. So she's 5, and she's in respiratory arrest, right? Not distress. As you begin to ventilate her with a BVM, vital signs are pulse of 64. Now, a pulse of 64 in a 5-year-old says to me hypoxia, because they're going to respond with bradycardia. Assisting at 20 times a minute, it's a good rate. Blood pressure for a 5-year-old, probably not so bad. 88%, yeah, not so good. So we found her in respiratory arrest, bradycardic, hypoxic, and we started ventilating her with supplemental oxygen. So after 5 minutes of ventilating, her vital signs now are pulse is 100. That says to me, when it was 64, that I've probably worked on that hypoxia. And the saturation of 99% tells me I've worked on that hypoxia. That's what we expect. So we're still ventilating at 20, but her blood pressure is now 60 systolic. Now it was 92 over 68. So what I've done is I've corrected her hypoxia, but for some reason her blood pressure has dropped. What does the question ask? I should suspect the change in her blood pressure, which is decreasing, is due to increased. Right now, that's the way I want you to look at a question that's full of all this information. And think about that. Pediatric hypoxic is bradycardia. And when I compare initially versus 5 minutes, I probably fixed the hypoxia because the pulse is up and the saturation's great, but the blood pressure dropped. All right, so the change in her blood pressure is due to increased. Well, it's not heart rate, because if I increase the heart rate, I'll increase my cardiac output, right? Remember, heart rate times stroke volume equals cardiac output. So if I increase my heart rate, I'm going to increase my cardiac output. Now, cardiac output times the vascular resistance, sometimes called systemic vascular resistance, equals blood pressure. So if I increase my systemic resistance, if I increase my vascular tone, I'm going to make my blood vessels smaller. Right? So my increase in systemic resistance is going to make my container smaller. That's going to increase the pressure, not decrease it. Now I have intrathoracic pressure and oxygen saturation. I don't know if I can raise oxygen saturation. Is that going to make my blood pressure tank? Have you ever heard of that? No. What happened? By ventilating, we've actually changed the intrathoracic pressure. When I take a breath in and let a breath out, that change in pressure helps move blood through my big veins in my chest. My inferior vena cava comes up and goes to my right atrium, and those changes in the positive and negative pressure help me move blood through those low pressure vessels. But when I'm doing only positive pressure ventilation, which is what I do with the BVM, not getting the change between positive and negative, I'm reducing preload. I'm not getting the the blood from those veins back to my heart, that I can actually tank the blood pressure by ventilating too aggressively? The answer, increasing intrathoracic pressure. Now, the other thing that I'll add about this question when you put this together is that don't let things intimidate you from the beginning. If you look at this and say, oh, don't do it. Say, okay, what I want you to say to yourself is, you read it the first time, you say, whoa, that's deep. Let me figure this out. And then go through and talk about it in your head, just like I did. You get a piece of paper or two there. You can write on it if you want to, work it out. You have the time to do this. But there's two ways to get a question correct. One is to know the answer. The other one is to know three of them aren't the answer. Either way, you get the question correct. But there are times the National Registry gives you a lot of information, but really, pretty much every bit of information in this question is necessary. There's no fluff. Think back to the video on when we talked about the difference between classroom questions and National Registry questions. They don't all have to be minimalist. The National Registry puts something in, it usually means something, even if it's a risk factor. Patient is hypertensive, patient has diabetes, patient has a prior cardiac history, patient has hyperlipidemia, hypercholesterolemia. Uh, you know, they take a statin like Lipitor or something. So this is the way that I want you to decipher questions. Now, not every question is going to all this information. Sometimes you get one sentence. I mean, you literally get one sentence and you have to make a decision. That's ultimately what the National Registry wants. They want, in this question here, have you basically understand pathophysiology and be able to apply it to solve a problem. Other times, especially in things like the operations module, you may find that you get a question that looks something like this. After being dispatched to a call, as the ambulance operator, you should ensure that. All right, you're going to look at that one. And sometimes the National Registry gives you a couple of big scenario questions and then hits you with one of these. And it's like, whoa. So then you look at it, you read it a couple times and thinking, all right. So you've been dispatched to a call and you're the ambulance operator. What should you ensure? So there are ways to sort this out as well, right? So if you look at this and say, after being dispatched, all right, do you ever say, ambulance 14, respond to a man down at, no, it's not the time you check the oil, right? Just put yourself in that spot where the fuel tank is full. No, right? We do that if we're really, really low. We don't call back in service until we get fuel, right? After being dispatched to a call, even look at this, see, everything makes a difference, and you're the operator, right? You should ensure that. Now, your partner is aware of your route of travel to the call, or that all occupants of the vehicle are properly secured. What would you ensure? Once you look at it that way, you say, holy cow, really, that wasn't so bad. Even though it looked kind of, gee, what could they possibly want from this question? When you go through and sort these out, this is the way I want you to be able to look at questions.